If we start recording. All right. All right. Good morning, good afternoon, and good evening, everyone. Welcome to the session 7 of Jazeera Rural Primary Care ECHO. And it is the last but not least for this year. I'm going to go really quick on our outlines of the session today. We will do a quick round of welcome and introductions. But for the sake of time and because we started late, we would really appreciate it if you can introduce yourself in the chat right now. We will go over our session reminders, and we will start the first part of our didactic presentation today. And it is an amazing topic and really important one, the principles of infection prevention across the healthcare continuum. And then we will be moving on to the second part of our session, case-based discussion with Dr. Mohanad. And last but not least, we will be having general Q&A. Just some housekeeping reminders. Please remember that discussion makes this work best. And I'm sure that Dr. Mathew would love to hear you all. So feel free to open your microphones or just raise your hands whenever you have any question. Dr. Mushtaba and I and Dr. Ahmed would make sure to go over the questions. We'd love to see your faces, so please open your cameras if you can. We know that the bandwidth and the internet connection problems in Sudan doesn't really help, but if you can, please open them. And a reminder to always please stay muted unless you're speaking or just raise your hand. And that this session will be recorded and the recap email will be attached, the certificate. So please make sure to join in using the iEcho platform so we can make sure we cover that part. And that to guarantee you get your certification by the end of the session. I would like to take a quick moment and thank the participants in today's session. We would like to thank the UNMC Hub team, Global ECHO team. Thank you, Aditi, for being here. ECHO India team as well. The University of Jazeera Faculty of Medicine faculty and the students, and our beloved guests. Thank you so much all for joining. So since this will be our last session for this year, we just want to stay and take a moment and thank our student coordinators. Thank you so much, Mohab, Kamil, Abdurrahim, Ahmed, and Farah for the constant work and organizing from the hub, the students, sharing around the slides and sharing the word to their batches. So thank you guys so much. Your hard work is admirable. And you know what they say, teamwork makes the dream work. So thank you. So without further ado, I think we can start our first part of the session for today. It is with Dr. Mathew, Dr. Trini Mathew. She's the medical director of the Antimicrobial Stewardship Program and Infection Prevention and Control at Beaumont Hospital. Thank you so much for being here with us, Dr. Mathew. This is the second time we've met her. We had her in the community medical response team program before, but this is the first time we have her here with us in the Jazeera program. So thank you so much for being here with us.
Thank you for having me.
Yeah, the floor is yours. So
Thank
I will
you.
just stop.
Yes, and I will share my screen.
All right.
Is that coming across okay?
Yes, everything looks good.
Okay, and I'm just going to move some things around here so I can see. So wanted to again thank the organizers first of all for this opportunity. And if I go a bit fast, please feel free to put some questions in the chat function. I get very passionate about infection prevention, so I might tend to go really fast when I'm trying to communicate. But feel free to chime in and let me know if you have any questions. So we will go ahead and, am I coming across okay?
Yes, we can hear you perfectly. But I just wanted to let you know, Dr. Mathew, that we have the allocated time is around 35 minutes. I will send you a reminder just before to let you know.
Okay.
All right.
So we will go quickly to talk about the modes of pathogen transmission, the hierarchy of control with regard to infection prevention, learn some of the differences in cleaning and disinfection and the use of personal protective equipment that many of you may already be aware about. So I want to first of all ask if you could put in the chat, what are some of your challenges with infection prevention? Feel free to put it in the chat, given our limited time, and we can bring that forward. Anyone wants to speak up or quickly put something, what your challenges are with infection prevention? And others can follow. Anything coming up yet in the chat?
We don't see anything in chat. Come on,
Okay.
guys. Don't be shy.
All right.
People in the hub, you can
As you
raise your
think
hand.
about it, please go ahead. Since we have limited time, I'll just go ahead with the next slide. So for us to understand about infection prevention and epidemiology, we also need to understand the pathogen transmission. And pathogen transmission usually is related with people, places, and things. That's how the pathogen interacts, and that's how we may have infections in healthcare settings. Anyone knows who John Snow is? Anyone in the chat wants to put in who is John Snow?
I believe the leader of the Night Watch.
Okay, wonderful, good to know. Any other thoughts of who John Snow is?
John Snow is the father of the modern epidemiology, I guess. Yes, he discovered the transmission of cholera.
Yes, thank you, thank you. So we do get someone who we are on the same page there, thank you. So that's the beginning of epidemiology. I think that's what we say, because he started evaluating the cholera epidemic in Golden Square, London. He started determining where people were and where they worked, who they are. He started developing a map of the cases around the water pumps. In other words, he was answering the question, the what and the how. And he started noticing this on the map, that there are some infections happening around pump A and pump B and C. He started noticing. So for example, you can see pump A, there are a lot of these dots cases happening. Pump C, hardly anything. Whereas pump B had some, but not many. So he started plotting this on the map, and that's some of the tools that we still use in epidemiology. We like to see where people are, we like to see where the cases are coming, and what are the objects around there. He noticed that pump B might be contaminated, so it's not being used, and many people avoided it. But people living across the other street from pump B went to pump A, but pump C was not conveniently located, and he found no cases around this one particular pump. And any thoughts about why? Anyone knows or can hazard a guess? Anything coming up in the chat?
Oh, we have nothing yet.
Okay. Well, as people are contemplating, we will take action and move on to the next slide. So he found that there were 89 deaths in 1 week. And a lot of deaths were happening one after the other. He started noticing. And what was concerning was over the weekend, the cases rose up and they had 79 deaths. So when you see things like that happening, you really need to start taking action right away. And you need to take urgent action when you see suddenly case mortality, case fatality rate going up very high. So he went from house to evaluate, and he found that the deaths were mainly happening around this street pump. So that's what we call a shoe leather epidemiology. Sometimes it really takes a lot of walking and talking to people to understand the problem. And those are some of the tools that we use in epidemiology. But of course, when Ebola happened in 2014, 2015, there are other ways to take care of epidemiology, not just a shoe leather, but sometimes you use other modes of transportation, including, as you can see, the World Health Organization's team going forward. So in other words, what happened was that when we are looking at epidemiology and answers, we need to find the who, the what, the when, the where, why, and how. So those are crucial things. Anyone knows what really John Snow then did when he found the deaths were happening so frequently, and what he finally decided to do? Well, he took action. He met with the people, he met with the leaders, and that's what sometimes epidemiologist does, brings the cases forward, meet with the leaders. But as I mentioned, with a high mortality, they had to take urgent action. And it was a simple tool what he did, simple action. They just took off the handle of the pump. And that was the way then people couldn't get water from that contaminated pump where potentially all the cholera cases were coming into. So sometimes you understand, and then you have to take urgent steps. But one key thing is when you're making an intervention, always bring your leaders together, talk with them, find out what can be done. And so it was a simple intervention that he did. And that's some of the principles of infection prevention. We always try to understand who are getting sick, how are they getting sick, why are they getting sick, where are they getting sick, and what can we do to prevent that infection from transmitting. So again, this is where we look for answers, not just in healthcare settings, but we also do what we call as contact tracing, going to communities. In the past, we used to call this infection control. The current paradigm is infection prevention, and that's what our goal is, to prevent an infection before it becomes a major outbreak. And why talk about infection prevention? Because in the healthcare environment, at least here in the US, we have so many areas that we have to focus on in infection prevention. Water, sinks, faucets, drains, ice machines that we have here. We have therapy pools for physical therapy and other activities. So water is a major problem. The other thing is dry surfaces. We may forget how many things are on bed rails, door handles, countertops. We have privacy curtains. So those curtains also potentially could be harboring pathogens, germs. We have construction renovation happening always within a healthcare facility, but also outside. So we have to think about the air handling that's coming into our communities. And that also holds true from the outside of a hospital into the hospital, but outside of a home or setting, and what's happening around there might lead to people getting infections. Our devices, the stethoscopes, the blood pressure cuffs, anything that we use potentially can also lead to infections. So a lot of areas for us to focus on. Now we do, yes.
Yeah, Dr. Mathew, sorry to interrupt. I think we just got an answer in the chat. It was from the John's question, what he would have done, the action take. We have an answer from Farha. She said that he would probably quarantine the people who got affected.
Yes, that's true.
Yeah.
That's true. And that's some of the strategies we do. So thank you for bringing that up. We'll be talking about that, definitely. So thank you. That is also one strategy.
All right, so, Dr. Mathew, if you can also just slow down a little bit.
Okay, thank you.
I think your guests are just following up.
Okay, wonderful.
Yeah, we'd love to hear you and understand everything you're saying and try to grasp it. Really good.
We may go a little over then, but I will have the slide decks for the people.
No problem. It's okay.
Okay. So why talk about infection prevention? Because we have so many reservoirs in the environment, as I showed in the previous slide, but also on us. Skin is our biggest defense mechanism against infections. So anything we do to the skin, any breach in our skin can lead to infections. And of course, the gut, we all have a lot of microbes, respiratory tract, of course. And of course, in the blood, we might have a lot of other pathogens that we are worried about. So the pathway then is by touch or by us breathing in or by splashes that we end up having potentially infections from one environment to a person, both the healthcare personnel or the patient. So what is the role of healthcare epidemiologists? I've been doing this for more than 10 years. I first started working in the field of tuberculosis, but then subsequently learned a lot in tuberculosis, and I realized that's where you can translate from tuberculosis into regular healthcare epidemiology into healthcare facilities. So what do? We start looking at our cases of healthcare-associated infections. We need to do surveillance. We need to understand the data. We also talk about isolation and disease pathogen transmission as a subject matter expert, as was mentioned about quarantining. We need to understand about diagnostic tests because nothing is 100% sensitive or specific, or most tests are not. So what does that mean when we talk about diagnostic tests? We talk about high-level disinfection, that is the HLD. The high-level disinfection, what is sterilization? What is low-level disinfection? A lot of things we need to learn when we're thinking about infection prevention. We also talk, of course, always about our hand hygiene, outbreak investigation, just like how John Snow's outbreak investigation was done, but sometimes we use other tools, of course. In this modern age, we leverage technology. In non-acute health settings, such as in our dialysis center, in psychiatric or behavioral unit, it's a different way of interaction of people there. And finally, we also look at antibiotic stewardship, because we need to work on controlling the unnecessary utilization of antibiotics that can then lead to unintended consequences, leading to antimicrobial resistance. So those are some of our challenges and what we work on. So I've shown the old tool. I wonder if anyone knows what this is called. I just found it interesting that we still have some of these available for us to remember how we would do work with technology. Any comments coming in? Of course, this is our save feature. Yes, yeah. Floppy disk, and that is, you won't even find that nowadays. Of course, access, you may have, the older epidemiologists may have some of these things stored there, but you can't access any of your data there anymore. So of course, that's what I meant. We leverage technology. A lot of data is put into secure cloud, so we can access it anywhere from wherever we are at. So again, we have to stay with the times of using technology to help us. And that's where a lot of testing is now done using machine learning, artificial intelligence, to help us know what is going on. So switching gears and talking about how do we prevent infections. Any thoughts? How do we prevent infections? I heard quarantine, so that's a good point. What else? Yes, I do see hand raised.
Yes,
Right,
go ahead, Farah. You may need to switch the microphone in the hall.
Actually, the hand raise is a good cue.
Farah, we can't really hear you. If you can try coming to the mic, closer to the microphone, there's an echo.
Yeah, if you're going to speak inside the hall, do not use your own phone. Use the hall's microphones, because otherwise there's going to be this echo. Or you can write your answer in the chat meanwhile. We also have an answer in the chat from Dr. Farha Bashir, who says that we should stop the chain of transmission.
Yes, absolutely. Absolutely. And actually, there's a cue that has been done with raising the hand. The first and foremost way to prevent transmission of infections is actually using our hands. Hands are one of the biggest ways that we transmit infections. So hand washing is really crucial. So let's talk about that. How do we prevent infections? We can learn from the past. Anyone knows about Samuel Weiss's story? Well, he was a great clinician in 1846, and he observed a higher mortality in women who were being delivered by medical students and physicians compared to the midwives. And they were wondering what was going on. These students and physicians had just completed autopsy. They had an odor on their hands despite washing with soap and water. And that's how he said, we need to do better. They started talking about using chlorine solution between patients, and the mortality rate declined. So in some respects, he's the father of hand hygiene or hand washing. From 1800s to now, we still talk about hand washing as one of the most crucial steps in preventing the transmission of infections. Why do we wash hands? Because all of us are colonized with a lot of bacteria, which we call as resident bacteria. And those are deeper layers, and they're less likely removed or associated with healthcare associated infections. But we also have transient bacteria that colonize our superficial layers of the skin and can be removed by hand washing. So those transient bacteria are the ones that can lead us to transmit infection from person to person. And that's something for us to be aware about. We do shed a lot of skin grains, and of course, microbes are part of it. And even something simple as a clean activity, we call as clean because we think there is no transmission, such as with a blood pressure check, checking a pulse of a patient, lifting a patient up. All those things can still lead to transmission of bacteria, such as Klebsiella that was studied. This is a photo of bacteria from a glove print. I had a student work with me, and the patient was in isolation for something else. The student was just having the gloves on, standing and not touching the patient, just the rails of the bed. And after he spoke with the patient, I was standing outside, and we just quickly opened up this plate, and the student did the imprinting of the gloves on it. And we went and looked at it after it was put in the incubation period for a while, right in the lab, they process everything. And we did see, clearly you can see strong prints of the gloves fingertips. And interestingly, it grew out gram-negative. So all these mucoid colonies, the patient was in isolation for gram-positive, but as you can see, the rails of the bed also had concerns of other bacteria. And this was just with the gloves alone. So again, as a reminder that wearing gloves alone does not protect us. We need to remember that we need to do hand hygiene even after we take off our gloves. So again, the most important way to prevent infections is good hand washing, hand hygiene. How do we wash hands? The World Health Organization has given us certain techniques as a reminder. How to use a hand sanitizer, the hand rub. And many times we just put it and we just do this or like this. But there are other techniques such as really getting in between. So I encourage you to try and do this. The cameras are off, but please try and do this technique now as we're talking. Think about making sure you develop this technique each time you use your hand hygiene product. Again, this is really crucial, not to air dry the alcohol, but really to keep rubbing your hands together. Similarly, with hand washing with soap and water, the same process the World Health Organization has said and given to us, the information. And one crucial step we forget is also when we turn off the faucet, try and use now a clean tissue to try and turn off the faucet, because there are a lot of microbes on the faucet also, and you've just finished washing your hands. So let's switch gears and talk about some cases. I see you, Fatima. Yes.
Yes, Dr. Mathew. I think if you can please just focus on the past point, because in Sudan, I think this is one of the main problems we're having. I worked for a month in internal medicine faculty in the hospital with Medini Hospital, and I think that we never even had water and soap. So I think it's really important if you can show us the right way to use rubbing alcohol and how effective is it really? Like even for medical students, because we have our medical students, they always visit the hospital as well.
I think when it first came out in the US in early 2000s, many of us were a little concerned. We still wanted the soap and water, but alcohol-based hand sanitizer is your go-to for any situation when you don't have access to soap and water. And in fact, it is really very effective. And so what you want to put a little bit, whatever that can come out. And actually the goal is to, as we have shown, is to rub your palms, but also the top of both sides, right? And then don't forget the fingertips, the nail beds. Those are small areas that we might forget. Then of course, this thing they have shown us with regard to around our thumb to make sure we get it very well. So these are really crucial steps. And again, those slides have the link to the World Health Organization poster. This is also from a while back, these posters. But again, this is really the best way, especially when you have no access to soap and water. And doing at least for 20 seconds will definitely make sure. Now, you may need to get a good amount if the product is drying out fast. If it is really not covering your whole hand, then you want to try and do it very well, add a little bit more. Some people will be like, oh, I put too much. Keep rubbing. It will dry up. It will sanitize your hand. So I think this is something really important to get the right amount. There are automated dispensers, at least in the US and some other places. I don't know what the feasibility is, but those are calculated to give you at least the maximum amount for what they consider the average size of hands. So it definitely would be to make sure that you do all these steps and you keep rubbing it nicely, so then you at least give 20 seconds to wash your hands, because this is the biggest way, the best way to protect ourselves and our patients from getting infections. And so again, this PDF posters, if you want to keep trying it, it takes a while to get used to doing it right. Even in the US, people don't, physicians and students still don't get the technique right. And there are certain hospitals, for example, my place here in Michigan, they are having people now go through a simulation center to make sure you do it right, because we have not been taught the right way. So it's always good for us to think about it and do it the right way. And these posters are available. This is something also to teach your patients in the communities. If they have access to the hand sanitizers, work with them. Work with children really young, then they can keep talking to their own parents about how do we do it right. So that's also something to keep in mind, training the newer generation of people in the community also. So work with them also. It will really go a long way to prevent infections. We will switch gears and talk about some information related to drug resistance, antimicrobial activities, and what we need to do. So talking about a case one here, we have an 80-year-old male coming to our hospital with chest pain. He came in for pneumonia a month prior, and it showed a bacteria type methicillin resistant Staph aureus, Staphylococcus aureus, which is pretty common in our communities. It was identified in the sputum culture. He's denying any cough, and the chest x-ray says there's no problem with his lungs. So he was admitted 1 month ago for pneumonia, but right now with chest pain, he's doing fine. So this is where I'm asking what the next step would be for infection prevention. Do you place the patient under airborne precautions, contact precautions, droplet precautions, or standard precautions? Any thoughts? Maybe these concepts are new.
All right, I think if it's something, can you please go to the previous slide, Dr. Mathew? I mean, I think if we can translate it into Arabic and go a little bit sorry. فشباب في عيان مريض في واحدة من المستشفيات عنده مرض صدري، قد يكون تي بي، نمونيا، أي حاجة. البريكوشنز اللي نحن المفروض نعملها شنو من الأربعة الموجودين دول؟ Do you think it's airborne? Do you think it's contact precautions? ولا standard? We have an answer in the chat. It says standard precautions.
Wonderful, wonderful. Yes, so let's go into understanding a little bit more about these precautions.
Okay.
So these are some of the modes of transmission and precautions corresponding to that mode of transmission. Direct contact is when the microorganisms are transferred from one infected person to another person through an intermediate object. And this includes when we have blood products with skin breakdown, when we're worried about what we used to know before with herpetic whitlow, where people would have the herpes labialis, and then potentially people were not, the healthcare personnel were not using gloves before, when we didn't use gloves, and they would get that direct infection by the virus onto the fingers of the physician, the dentist. So those are some things that we used to be aware about. The indirect transmission is transmitting through an intermediate object or person. Again, this is via hands. So one person transmitting to the next person with contaminated hands, non-sterile equipments, and our personal protective equipment. So contact transmission can be both direct and indirect. So there are two ways that we could be transmitting infections. Then we also have other things to consider, and those are our gadgets. And this is a study that was done in Detroit, Michigan a few years back, where they just looked at the house officers, the residents, the attendings who were carrying their portable electronic devices, which is like phones and cell phones, your laptops, anything like that are called as portable electronic devices. And when they sampled it, you can see the percent of positive cultures coming from these devices. A lot of them was just skin bacteria called as quag-negative staphylococcus, but you can see the MRSA, Pseudomonas, concerning Staph aureus, and a lot of other gram-negatives were also on our cell phones. So we need to be careful what we do with our cell phones when we, especially examining a patient, when we suddenly pick up the phone to talk, and then we don't do a hand hygiene and touch the patient. That's observed in hospital settings in the US. And that is a habit we all have. We respond to a call, we respond to a page, and then we forget to do a hand hygiene and go back and examine a patient. So something for us to be aware about. A lot of gadgets also transmit infections. The other route is droplet. And you may have, of course, encountered this conversation during the COVID-19 pandemic. It is a form of contact transmission, but it is through the small, tiny droplets of water that when we breathe out, pathogens are on it. And then this infection travels directly from an infected person's respiratory tract to the mucosa around here. So for the next few minutes, what I encourage you to do is think about where your hands are. Are your hands going to be touching your face over the next 5-10 minutes? Keep monitoring yourself, and then later on, we will see how well we've been doing with that. Again, direct transmission happens with our hands, potentially, or any object, for example, a contaminated pen, anything that can have contamination, stethoscopes, devices, cell phones. But also when we speak or when we breathe out and we have some things coming and hitting our mucosa around our face. So think about it, how much we need to protect our face. And these droplet viruses or bacteria actually do not remain infective over long distances, and they drop down. And therefore, we do not need special ventilation systems in place for the droplet route of transmission. But the airborne transmission is usually by very small droplet nuclei that we can inhale fully into our lungs, and they stay infective over long distances and time. Do you folks know one form, or at least one or two pathogens that potentially you can get infected through the airborne transmission? Thoughts about that?
We have an answer in the chat.
Yes.
This is tuberculosis and measles.
Thank you. Spot
Example of
on,
airborne
you folks. Yes. Tuberculosis, the hidden bacteria that stays on for years in a latent form. Measles comes on quickly, and that is a viral infection, one of the most contagious pathogens that we know about. It can stay suspended in the air for even 2 hours after the person has left the room. So those are some things that we really need to be careful about. And tuberculosis is slightly different, but it stays in the body for a while before it activates. And so that's something also we need to be aware about. So other things that we need to be concerned about in healthcare facility is what we call as pathogens or microbes that have more of a risk within healthcare facilities, such as those that can be occurring certain time periods or geographic clusters. For example, you have burkholderia that sometimes is related to specifically in certain locations in the world. Now in the US also we picked up burkholderia pseudomalia in soil, and people can inhale it at certain periods of time. Then we also have certain pathogens we're concerned about, as I mentioned, MRSA, vancomycin, intermediate susceptible Staph aureus, vancomycin resistant Staph aureus, much more concerning, vancomycin resistant enterococcus, and what we call a whole spectrum of ESBL. Okay, you've got that going, thank you. Then these pathogens we look at, as I said, for health epidemiology, look at the surveillance, look at the trends to understand, are we suddenly seeing a lot more patients coming in with this? Are we picking this up in our clinical cultures? Some of these pathogens are really hard to treat because they are inherently resistant to a lot of classes of antimicrobials, but some acquire resistance fast, and they have very high morbidity, meaning people get very sick if you have Staph aureus that is either susceptible or resistant. Group A streptococcus can cause high morbidity and high mortality. You may have heard about it in the news that there's a concern now that's going on. And so those are things that we know from the past. They're not emerging infections, but something is happening that is leading to more people falling ill, for example. So these are some of these re-emerging pathogens that were existing, but we also have the new pathogens, of course. So multi-drug resistant organisms, those are definitely something that we have concerns about. They are resistant to one or more classes of antimicrobials. And this is something where infectious disease physicians, we get very concerned when we don't have antimicrobials to treat them. In 2010, there was this article written called as the escape pathogens that were classified here. And unfortunately, these pathogens still is of concern to us because many of them continue to have resistance, developing newer resistance to each antimicrobial class that is generated or built or developed by pharmaceutical companies. So infectious disease physicians, we are the first to always say, let's not try that new antibiotic, not yet time. Unlike those, for example, related with when you're treating hypertensive cases, you start with a newer drug. In infectious disease, when we get a new antimicrobial, we are saying, let's be cautious. Let's not start it right now because we might have drug resistance quickly happening. So we are very careful with what we have left. Yes, that's a question.
Yes, we have a question in the chat. It's from Abdurrahim. He's asking what ESBL stands for. I believe it was in the previous slides.
Yes, extended spectrum beta lactamases. That is a group of, that is the resistance that happens to certain bacteria. And that means that your antibiotic choices are lesser and you have to then use another class of antimicrobials, which is frequently what we bring out then as a carbapenem. Unfortunately, with a lot of exposure to that class of antimicrobials, then you get CRE or carbapenem resistant Enterobacterialis, or even carbapenem resistant Pseudomonas. So those are the classes of drugs that we have to then scale up to if you have an ESBL. And then unfortunately, we might make the patient have a CRE. So again, those are some of the ways how we try and what we talked about earlier, antibiotic stewardship. Great question, thank you. Now, it's not just bacteria. We're worried about fungi. And one of the main concerns right now, for example, here we have faced in Michigan is, and in the US, is this class of antifungal resistant class of Candida auris. And this was initially reported out, as you can see, in just a few states in the US. But after the pandemic, we have had a major rise in resistant Candida auris. And in Michigan, we never had any case till what was detected in 2021. And now suddenly our epi curve has really gone up. I'm not sharing that, but this is again one of the unintended consequences when we don't clean properly, we don't disinfect properly, we start using antimicrobials, and then we expose our patients to a lot of procedures without doing proper cleaning, or we expose them to devices such as central lines, ventilators, things like that, that might lead them, unfortunately, to get colonized with a resistant fungus such as Candida auris. This is information that was shared with us by the head of the mycology branch of CDC at a local Michigan State Infectious Disease Society meeting in November. And again, it shows us where Candida auris stays in the environment and can persist in the environment. And we need to do specific cleaning, use specific products for that. How do you prevent Candida auris infection, for example? Again, talking about what we said earlier, what one of the attendees said, quarantining, we place them separately, and then we also have to make sure we wear the right PPE. And of course, the most important thing, as I said, is about hand hygiene. This is example again of what it entails. After just 5 seconds of contact with the bed rail and bedside table, healthcare personnel had positive hand cultures with even what we call as vacant or clean rooms. So cleaning is really crucial. So let's talk about cleaning and disinfection. What are your challenges in cleaning and disinfection, and what makes you decide when to clean or when to disinfect?
التحديات يا شباب اللي ممكن تلاقينا لما نكون في المستشفى في الكلينينج، النظافة والتعقيم، التحديات اللي بتلاقي لنا شنو؟ والحاجة اللي بتخلينا ذاته نحدد إنه الحتة دي حنعقمها ولا ننظفها والحتة دي حنعقمها شنو؟ What do you guys think? We have an answer in the chat. Someone says that challenges are getting people to clean their hands with a high patient load.
Yes, yes, that's true. Hands are important, but the environment also needs to be cleaned and disinfected. So that's what we'll talk about. So what's the difference? Cleaning is the process of removing dirt, germs, and other kind of stuff on surfaces and objects. So let's even think about our homes, right? We first sweep, removing all the germs or dirt that we can as much as possible before, for example, we would mop, right? So disinfection is a different step where you try to kill as many germs as possible from surfaces and objects. So we first have to clean, try and decrease the dust, germs, other things that's there, and then use a disinfectant product to really get into and kill as many germs as possible. Now, in the environment, you can only do this when you have certain ways and certain processes in place, and that's something we'll talk about. But at a minimum, you need to think about cleaning in a hospital or in a clinic, all those high-touch surfaces, such as door handles, light switches, if you have using a bedpan, of course, toilet handle holes, all those things, for example, in the US, we say are really high-touch surfaces, but also the equipment we use, such as the machines for checking blood pressure or pulse, glucometers, even any of this radiology equipment that we use, devices, and again, don't forget your stethoscopes that you use. So those are some of the things that we have to think about, not just cleaning, but disinfecting also. In a healthcare setting, there's a process to do this. The place where the patient is lying with the direct contact are actually some of the highest microbial burden areas. The outside of that area has lesser microbial areas of burden there. So that's this concentric way. And you try to go from the cleaner to the dirtier areas or to the center. And that's, for example, how CDC has shown us an example of cleaning strategy. This is another way when we think about cleaning around the patient's bed, you think about going in a systematic manner. Again, if their body spills fluids, they really need to be cleaned up right away before you even think about disinfecting. So there are certain techniques, and even in homes and communities, these are certain techniques to think about. You always start off with the cleaner area and then go to the center or the dirtier area. So that is important to keep in mind. The other strategy is always you start from the top and then you go bottom. In other words, you start from the top of tray tables, surfaces, countertops, then you clean the floor. So again, the top, and then you go to the lower part, the lower level for cleaning. So certain strategies that you can also use in your homes when you talk with patients and your own family members and communities. The other piece to keep in mind is also about knowing your disinfectant. And this is very true for us, even in the US. Many people don't know. We have this conversation in healthcare settings. How do you know what product to use and how long to use it? And for that, we have something called as a contact time. The disinfectant is manufactured to give you a certain level of killing of different microbes, but that level of killing can be achieved only if that disinfectant stays wet or stays in contact with that object. So if you don't use the right product for the right amount of time that the manufacturer said, you are doing a disservice. You are not disinfecting. In other words, if you say, oh, I've used the disinfectant wipe and that object is too wet and I just need to get the patient in, then you have not disinfected. You have ended up potentially defeating the cleaning process and the disinfection process. You need to make sure that the disinfectant solution or the wipe stays wet for the amount of time that the manufacturer said that it will do the job of killing the germs. So something for you to keep in mind. When in the US, I see frequently in healthcare settings, the wipes that we have in the canisters, the tops are left open because people pull out a wipe, is left open, the product starts drying up. It won't be able to do the contact time required time for killing if the product is already drying up because it's not closed properly. And some of these things to keep in mind if you have access to wipes is, again, look at how long does it take. Just like with hand hygiene, we need a certain minimum amount of time to try and keep the product on the object. So I'm just emphasizing because people do not use it correctly. Is there a question?
No, there's no question so far.
Okay, all right. Sorry, I thought I saw a hand raised. So let's quickly switch gears. We have a case of a 60-year-old male coming in from a corrections facility in the US, admitted with fever and cough for 3 weeks, and the chest X-ray reveals pulmonary infiltrate, so there's something going on in the lungs. The patient does have yellow sputum. He has also HIV with very low CD4 count, so his immune system is really low, but he's on treatment, so that's good. So now in this person coming in from a corrections facility or from the prison system into your hospital, into the ED with cough, and he's immunocompromised also, what are some of the concerns you may have and what precaution do you think the patient needs? Airborne, contact, droplet, standard.
So يا شباب بس عشان الكوركشنز فاسيلتي ممكن يكون سجن، ممكن يكون اي حاجه، فالبيشنت ده جايين من المحل ده وهو عنده immune deficiency. CD4 counts حقته low شديد والاكس-راي بتاعه is not normal فيها infiltrate. ف now knowing ال precautions كده رايكم شنو؟ What type of precaution؟ هل airborne ولا contact ولا droplet ولا standard؟
I see Kamal Hassan has raised hand.
We have Kamal. Yeah, please
Go ahead.
It is contact precaution as she is already immunocompromised. As the patient is already immunocompromised, I think contact precaution is most important.
Sorry, I didn't fully. Something about immunocompromised, and what's the question?
I think contact precaution. Yes. As the patient is already immunocompromised,
Okay.
we have to make a contact precaution.
Got it. Okay, so you are proposing we have the patient under contact precautions, and you are because of he's immunocompromised. Okay,
And
so
I
that
think
is an option, but there's something else in the history of his presentation we have little concerns about, and it may be just specific for the US. So just wanting to share that. So thank you. We'll go forward.
the
So-
answers in the chat, they're split between airborne and contact.
Okay,
So
thank
we
you,
need
thank
to
you.
answer. Mhm.
Yeah. So in the US, what we would have been concerned is about the immunosuppressed state, the immunosuppressive condition, and what predisposes them to have other infections when they're immunocompromised. If they did have skin lesions, like open lesions, some vesicles, or wounds that we think might have severely drug-resistant bacteria, we'd have definitely put contact precautions. Now, that is to prevent the healthcare personnel from getting infected. Now, because they're immunocompromised, there's another precaution that sometimes we do, which is more of protecting the patient. And that might be what we would call as a protective environment, and especially when they're on transplant units, when they've had solid organ transplant and I think they're severely immunocompromised. But usually it is when they are receiving chemotherapy and they are on what we call as bone marrow transplant unit. But it's more of a protective environment precaution that we would place them under. That is to protect the patient from others coming in and causing infection. Whereas in this scenario, we would be thinking about, can the patient infect other patients and infect the healthcare personnel? So in this scenario, for this person, we would have considered tuberculosis as a risk potentially, because the person was living in a congregate setting where a lot of people are mingling together, and he's immunocompromised. So if he was already exposed to tuberculosis and had it as latent tuberculosis, he could reactivate with a coughing and cough out the bacteria and infect others. So we would have placed him under airborne precautions while we figured out what was going on. So that's where we will be talking now about thinking about tuberculosis. Anybody knows what happened in 1882, March 24th, 1882? Well, for interest of time, we will go down quickly down the history pathway. Mycobacterium tuberculosis was discovered, and that was announced by Dr. Robert Koch, who discovered Mycobacterium tuberculosis. And at that point, tuberculosis was killing a lot of people. And so it was of concern, of course. And then later on, this date was recognized to remember about tuberculosis. In 1982, World Health Organization and the International Union Against Tuberculosis and Lung Diseases proposed the first World TB Day for educating public about tuberculosis. We've had many themes every year proposed around March 24th. And I encourage you to explore that also when you're working and talking about tuberculosis there at your local communities. So these were some of the themes in the past. And it said about stop TB in my lifetime. But fast forward 2022, unfortunately, a decade later, we're still talking about TB. Invest to end TB, save lives. So stay tuned. March of 2023, March 24th, there'll be a lot of information coming about talking about tuberculosis. You may be very well aware about tuberculosis transmission. It can stay airborne for long periods of time. It is not transmitted by surface contact. It's by the droplet nuclei, really small ones, airborne, that stays and gets into an alveoli. And it really depends on the concentration of infectious droplet nuclei. When in the US, when we suspect someone may have tuberculosis, then we need to think about, okay, is the patient potentially going to bring it out into the environment with any coughing or talking loudly even? You have to think about it. And you have to think, has the patient been on treatment? Chest X-ray will show us the classic findings, but in people who are immunocompromised, including people with underlying HIV infection, drug use or diabetes or kidney failure, you might have varied presentation. Now, this is from the US MMWR from 2005. They've used the word alcoholism. The right term is alcohol use disorders, but just letting you know that anything that suppresses our immune system can potentially lead to a varied presentation of tuberculosis on the chest X-ray. So it won't be the classic cavity that you might see. When we consider tuberculosis, we need to start the patient on placing the precautions. We order the precautions, we make sure the patient can go into a specific room with a negative pressure room and isolation precautions. We obtain sputum samples. And the most important thing is to educate our physicians. Even in the US, people forget about tuberculosis frequently because you're not seeing many cases. And they forget that a person could have been infected many years ago and come down with tuberculosis. So we start all this and we start talking about having conversations. We also initiated when a patient has signs or symptoms or concerned that the patient has not yet completed a proper TB treatment and might be still spewing out the bacteria when they talk or cough. So we start those precautions. All these rooms, optimally, we need them in private room, we say, with a private bathroom. We talk about the ventilation, and healthcare personnel need to go in with the N95, which I'm sure all of you are now aware about because we've talked about it in COVID-19. So quickly going through this photograph as a reminder from a while back that I found on Microsoft PowerPoint, how they showed a respirator being placed. What's incorrect is the way how it's placed. It's not getting you a good seal. And so just for interest of time, just sharing certain things, potentially as a reminder how to take care of and in case of taking care of a TB patient. We do educate healthcare personnel on the right way to use the N95. And this is from a while back that we had these products to show how to use it right and how to take it off so that you don't contaminate your face when you touch the mask and when you take off the mask. And you have to be careful and do your hand hygiene. In the US, we try and put some policies in place. That's part of our infection prevention. And then we also talk about who should get what mask. Many times I see the nurses giving up patients N95 mask, and I said, actually, all they need is a surgical mask to kind of help do a source control while they're waiting for getting some procedure done. We have to keep the doors closed, again, make sure the negative pressure is working. And there are a lot of these kind of balances that we do, checks and balances to make sure our infection prevention programs are working in a healthcare setting. And that's where I bring forward to you one of the other objectives to talk about the hierarchy of controls. Everyone has been talking about PPE over the past few months and years, but actually PPE is the least effective way to prevent infection. The first step is elimination. Can you remove the hazard? If you can't, can you dilute or replace the hazard or substitute it? The next step is engineering controls, which the key thing, as I pointed out, was the negative pressure room. Then we also think about changing the way people work. You might have heard about it, about the social distancing, the spacing of workspaces, and then finally the PPE. So these are certain things that we look at. The most effective, of course, is elimination, which is sometimes what we do with doing the quarantine or doing the isolation. And of course, the least effective is PPE, but we still need to use it. Quickly talking about this case, 20-year-old coming in and having headache, fever, decreased mental status, young patient you see, generalized rash, non-blanching, and petechial rash, no vesicles. Just thinking through, what do you think the patient needs? Airborne, contact, droplet, standard. What do you think the patient may be having?
Patients may have meningitis.
Thank you. Yes. Yes. So these are important decisions quickly to make when you see or hear. When you think about young people, potentially, especially in the US, we talk frequently about people living together in dormitories, like in colleges. And the sequelae of meningitis, bacterial meningitis, is pretty bad. So you need to make sure healthcare personnel are also protected. So droplet precautions you start the patient on. So this is an example, as you can see, that CDC has taken this photograph to show how bad it can be when someone coughs out, and you can potentially end up having infections transmitted and spent there. So that's what we talk about, the source control and the cough etiquette and other things. So just as a quick reminder of how bad it can be when someone coughs out, the number of droplets, some of them are large, they will fall down. Some of them are really small and they can stay suspended for a while in the air. So there's been this confusion around COVID-19, droplet, airborne, and the classic airborne infections we just talked about, as you all mentioned, was measles as a viral example and tuberculosis as a bacterial example. But there are a lot of other viruses, as you know, that causes droplet, the common cold, the common coronaviruses that we knew about even before the novel pathogen. So I just want to remind you about that. The common cold is caused by coronavirus. And then we need to be aware about a lot of other infections that we have. For example, in the US, we do a respiratory viral panel. If you're really suspecting a lot of infections that can be viral, we've had a major now uptake of influenza, for example. Respiratory syncytial virus has gone up here in the US. You have the usual rhinovirus, adenovirus, parainfluenza, and as I pointed out here, a lot of the coronaviruses that we knew about before COVID-19. This is just a recap about the prior SARS virus that we had, the first pandemic, the beta coronavirus. You may be aware about the Middle East respiratory syndrome, all related to the coronavirus. And then, of course, the COVID-19 that we have still undergoing. Remember, every breath sends out a cloud of respiratory droplets that can be potentially a risk of infection. And there are ways for us to stay protected using source control for the patient with a surgical mask and to cover the nose, the mouth. Avoid frequent touching of the mask. Use fresh mask each time after meals, lunch, coffee breaks, because a mask is usually for single use. So you really should discard it. For the right way, educate your community members, the right way to do it. We frequently do this constantly in the hospitals, reminding the staff, not under your chin, it's not helping you, not under your nose, it's not helping you. So discard it if you're not putting it on your nose and mouth. And then the important thing again, hand hygiene, because you can infect yourself after you take out your mask and if you did not do your hand hygiene. N95, other respirators, this is the percent efficiency in removing other particulates, 95%, and it's not necessarily 100%, you can get a higher level, but N95 is what we use with all the other controls we place. People forget about doing a good seal check to blow in to make sure that the air is not coming out because you might have not placed it well. It won't protect you if you don't do a good seal check. You also need to get a proper fit testing done annually or more frequently if you've suddenly gained weight, lost weight. So those are some things. And people can't fail their fit testing. And so it's important to make sure. You can use your PPE. It will only be effective if you use it correctly. And this is, again, an example from CDC. People frequently start wearing the mask first, but the first step is, of course, washing your hands, putting on your gowns. Make sure the gown is covering you well so that your clothes don't get contaminated from the environment of the patient. Make sure you also put your face shield properly, your gloves over your gown, and don't forget you should be washing your hands even before you put on your gloves. When you take off, you first take off your gloves, the most contaminated part, take them off. Don't forget to do your hand hygiene very well, all those cleaning that you need to do before you touch the rest of your body to start taking off all the other PPE. And finally, again, hand hygiene. In between also, when you take off your mask and other things, don't forget to do your hand hygiene. Again, this is something we have from CDC. I'm not sure what you may have access to, but I just put some infographics. And in summary, for infection prevention, both in the hospital setting or in the clinics or in the community setting, remember hierarchy of controls. The first step is try and remove the hazard, the source control for patients, or when you go to see someone in their homes, if they're coughing, encourage them to wear a mask. And of course, you try and wear a mask too. Washing hands frequently, carefully wearing and taking off your PPE. Again, the hierarchy of control, social distancing, which is the same thing of administrative control. How do you get people in properly? Avoid crowded settings in the waiting rooms. And again, what was already mentioned, self-care and also self-isolation, quarantine. And then don't forget vaccinations. The best way to prevent infection is taking advantage of vaccines if you have it for those infections, and then giving yourself immunity boosting through the vaccines. So with that, I'm happy to take other questions. And I'm sorry, Fatima, if you may have gone over, since we started a little late also, I might have gone really over. Sorry about that.
No, timing is perfect. It's okay. We have additional 15 minutes. So thank you so much, Dr. Trini. That was a lot to take in, but
Yes.
everything you said is so important. So I think I can share my screen.
Yes, let me stop
Yeah.
sharing this one, please.
Okay. All right.
And I can see the chat.
Yes. So any questions or comments for Dr. Trini? I believe there was a question earlier. It was they were asking about, can you please clarify more what we mean by a negative pressure room?
Yes. So negative pressure is the flow of air into rooms in healthcare facilities. So you exhaust the air within the healthcare facility is exhausted out of the facility. So it's a negative pressure that you do working with your facilities engineering controls. And you can do a tissue test. What we say, we just put it under the door and then we try to see which direction the tissue is going. So in other words, the air that the patient is in, the room where the patient is located, that air is not going back into the facility, into other rooms, but it's being taken out. And that is the optimal way to do a negative pressure room. But during COVID-19 times in the US and many other settings, we also put in place what we call as the portable HEPA filter, which is a filtration process to kind of filter out the contaminants that might be in the air as a way to decrease. So one way for you to remember is, and I'm wondering, Fatima, if you could translate this, we say this frequently, and this is from other industries we learn, dilution is the solution to pollution. It's just a way of saying that if you have a lot of particles in the air, you want to dilute it. So if there's a pollution of a lot of particles that you want to bring down, you dilute it. And that is the solution. So in other settings, if you can, keep the windows open for nice cross ventilation. So when I was visiting a clinic in India, and I was concerned, we were working with immunocompromised people, the physicians were there, and some of the patients would come in and had a mask on. The physicians were wearing the mask on, but what was really crucial and how I positioned myself was close to the windows so that the fresh air would be coming in, will dilute out if there's any concern of people breathing out or coughing up any viruses or any bacteria. So ways to think about protecting yourself. Negative pressure is one way in a healthcare facility, but even in the US, we don't have many rooms with negative pressure. So when we need to, we think about other ways to dilute out the concern about risk. But remember, whenever you do something, there might be unintended consequences. You could also bring in fungal spores. You could also bring in other concerns, but if you are examining a patient and you have concerns and you have an opportunity to do it, you could avail of a negative pressure room if you have access to it.
I hope this answers your question. Yeah. I don't see any more questions in the chat, Dr. Mathew.
Thank you. I'm kind of interested to
So
hear
much for this presentation.
how are people thinking through about how to handle seeing patients with tuberculosis there or measles there? What are some of the solutions you have adopted there?
I think the question is directed to our family medicine and primary.
And I see a question came, if person has contact with TB patient, what to do? Yes. So I think, so let me just take that question. If a healthcare personnel has had contact to tuberculosis, what we do in the US, for example, is you get monitored. You have what we call as contact investigation. We go to our employee health. They do a skin testing, or nowadays we have the blood draw to see what our status was. And a few weeks later, they repeat it to see whether we have converted or have a positive test after our most recent exposure. In the US, every healthcare personnel, before they start employment at a new place, end up being screened for tuberculosis. And so in the healthcare setting, when we have an exposure to tuberculosis patient, they will again recheck to see. So that is something for you to be aware about. In the US also, we have healthcare personnel who have a positive test of knowing that they have been infected in the past. And so what we have recently recommended is that they be monitored and actually be offered treatment for what we call as latent TB infection. Any one of us exposed and infected can break down and have full-blown TB later on in the future. Especially as we get older, remember, our immune system weakens. If we end up picking up diabetes or any other immunosuppressions, we could flare up and have tuberculosis and spread to our families and to our patients. And in the US, we've had cases like that also. Healthcare personnel transmitting tuberculosis to others, including patients. So the recommendations are really for healthcare personnel to try and suppress that latent infection also, completing a course. And that is, of course, a whole different topic for us to go through. But I just wanted to share, if you are concerned that you've been exposed with tuberculosis, you can be tested to see whether you have converted and got a positive test. And we do recommend chest x-rays, imaging to see how your lungs are doing. And then also every year having a conversation and thinking through any of the signs or symptoms of tuberculosis, because healthcare personnel may forget that they were infected, and the cough that they've been thinking, oh, it's just allergies, may actually be tuberculosis, and they can infect others. So annual symptom screening is a good idea to have if you have concerns about potentially being infected with tuberculosis. But if sooner, you will need to be evaluated if your symptoms happen within 3 months of infection, you start noticing cough that is just not improving. So some things to consider. I hope that helped answer that question about what to do if you're in contact with someone with tuberculosis as a healthcare personnel. And I think I saw the response to my question. What do you do if you have a person with tuberculosis or measles? I think we put them all together in a separate place. So you try to get them in an area where you can isolate them. So therefore, a new person who is susceptible to infection does not get, for example, infected with measles. But I also hope that there are opportunities there for good vaccination programs to protect us against measles. Is that something that is feasible there to communicate with families and patients? Measles vaccination?
Yes, and that's one of the main goals of the University of Jazeera. I believe in every rural place, there's rural clinics, and one of the main important things are vaccination programs. So almost all children go to their the primary care clinic they have in their area, and they get vaccinated for MMR, measles, mumps, and rubella together.
Yes, thank you for sharing that, because I just want to highlight what's happening here in a neighboring state. In Ohio, there's a major measles outbreak. In Michigan, in spring of 2019, I had to respond to a measles outbreak happening very close to in our community, and patients coming in unaware that they were having measles and walking through a hospital. So when people don't get vaccinated fully, then there's a risk of outbreaks of measles happening anywhere. And right now in Ohio, for example, they are working on that outbreak because the children were not fully vaccinated due to the pandemic and other concerns. So just wanted to share that. Thank you.
Yeah, thank you. Thank you so much for sharing that with us. Good to know. So for the sake of time, Dr. Trini and everyone, I think we will move on to the second part of our session. We would love for you to be here with us and to hear your input on this. As well as the faculty from University of Jazeera, we would also love to hear your input on this, especially so it relates to what's happening on in Sudan. So we will start.
Can you hear me?
We have a hand raised. I think it's Kamal. Yeah, please.
You can hear me?
Yes, we can hear you.
Okay. So the case goes as follows.
Mhm.
The
All right, it's Muhammad. Okay, go ahead.
23-year-old manual worker comes to the clinic in autumn, complaining of vomiting for 3 days. He says he's not sure what started and that he has been eating at his usual places, yet suddenly started having bouts of vomiting and profuse watery diarrhea. He lives with his wife and 7 children, says that multiple members of his family have been having similar symptoms, and that it has been hard because they live together in a 2-room house. His temperature is 38 degrees centigrade, that is 100 Fahrenheit. Pulse is 105 beats per minute. He also has poor skin turgor. IV fluids are administered. The questions for discussion today are: first, what means of protection should the team treating this patient use? السؤال موجه لكم. What means of protection should the team treating this patient use? He has vomiting for 3 days. He's been eating at his usual places, yet suddenly started having bouts of vomiting and profuse watery diarrhea.
Do we have an answer at the hub, Muhammad?
No, we don't.
Okay. So guys, what do you think? What do you think? Muhammad, if you can like just translate it and summarize it real quick. باختصار كده.
في عامل عمره 23 سنة جاء العيادة في فصل الخريف، عنده استفراغ مدة 3 أيام. قال إنه ما متأكد البداية شنو، لكن كان بياكل في الأماكن العادية بتاعته، وفجأة جاءه استفراغ ووتر دايري. هو بيعيش مع زوجته 7 أطفال، وبعض الأطفال الثانيين من عائلته جاتهم برضو الأعراض دي، وهم عايشين في بيت فيه غرفتين. عنده حمى، درجة حرارته عالية، والبلس بتاعه زايد. الفريق اللي بيعالجه المفروض يستخدم. طيب تفضل. You have a participation.
Hello, everyone. Firstly, he must use anti-vomiting. in order to stop this vomiting. And after that, we must use
We can't hear you. The University of Jazeera Hub. We heard the answer that they should start using I believe an antiemetic. But then it cut off. So can you please summarize it? The answer. You can feel free to type it in the chat. We do have a couple of answers in the chat. We have an answer for Fatma Hassan. She says that washing your hands and using a disinfectant to clean the room. We have a beer. She also says hand washing, and I said contact precautions. So I think the first question. So what do you guys think? Is that airborne, contact, droplet, or standard precautions? What do you think?
برضه فكروا في الحاجات اللي قالت الدكتوره قبل اللي هي انواع الكونتاكت المفروض نحن نعمل لها بريكوشنز اللي هي الايربورن او كونتاكت بريكوشنز او دروبلت بريكوشنز ولا ستاندرد بريكوشنز دي حاجه قاعد الدكتوره قبل فثينك اباوت انه يد واحد من انواع الكونتاكت دي المفروض نحن ناخذ لها بريكوشنز. I think we have an answer from
I think we can use a contact precaution as a means of protection.
So I just wanted to chime in. I really like all the answers coming out. So when you are concerned that you might be exposed to body fluids, you want to take all your precautions, and that's what we call as standard precautions. For example, if a nurse is going to clean a patient and the patient is suddenly having diarrhea, they should be already wearing the PPE, meaning the gowns and the gloves. And those are some of the things as our standard precautions based on what we call as syndromes or concerns of potential exposure. We don't know what the patient may be having, so we use our PPE to keep ourselves safe and our next patient safe. So here you'd already know someone is already throwing up and is already having diarrhea. You have to think about things such as norovirus. In the US, we always think about in the winter season, because those particles are very contagious. And so you really want to make sure that you don't accidentally get it. In US, especially, many households start really getting one person falls sick, then everyone falls sick because they end up sharing the same bathroom. And these droplets are there. No one has had time to clean. So I saw something about disinfection, definitely needed, but your best solution, for example, to keep yourself safe as a healthcare personnel is wear your PPE. Make sure that you do not get exposed to whatever this patient is having or his household members are having. So gowns, gloves, definitely you use it if you're seeing them in the ER before you even start the precautions. If you think that things get splashed on your face, don't forget to cover your face with a face shield. Sometimes people might vomit and they don't have a chance to control. So just throwing out ideas, use your PPE to keep yourself safe.
Thank you so much for the input and for answering the question, Dr. Trini. I think, Mohamed, we can go to the second question.
Thank you so much, Dr. Trini. Now we'll move on to the next question. What preventative measures could have protected this family? And what interventions by the Ministry of Health may have helped? العائلة دي كان ممكن تعمل شنو عشان تحمي نفسها؟ والتدخل من وزارة الصحة ممكن يكون شنو؟ Yes, far.
I think by maintaining sanitized water resources and cleaning food and water intakes before consuming them.
And something that I want to add also is that think of the setting of this
can also
patient.
provide a chance for free check for the family members for such disorders and most successful diagnosis for this patient.
Yes, that is correct. Something that I wanted to add is the fact that you should also put in mind the fact that this patient is coming in autumn, and in Sudan, autumn is the rain season. So that's when we usually have outbreaks of water diarrhea, such as this patient. And we've had outbreaks of cholera before, especially in the state of Jazeera. So that's something that you should also be putting into your mind while you're trying to fix this family's problem.
I think that's why most of the answers we have in the chat right now is the preventive measure will basically be washing the hands, washing the food. We have an answer also, the isolation of the patient, try to isolate him in a separate room, even though he lives with his 7 kids, and it's kind of a little bit hard, as the case says. But we can try our best to at least try to isolate him to a place where away from the rest of the family. And it's a 2-room house. So
one option that you may consider is cohorting them. That's what we call as cohorting. People who are infected, especially households, and this is also true for tuberculosis patients, right? People living in the communities, in their households, they've already shared the pathogen. But those who are not yet symptomatic, maybe you could try and move them away. Similarly, like when we had the COVID-19, we would say, if you're not yet symptomatic, try and take all your precautions. So all the hand hygiene, that's all brought up. I don't know who could help all the other family members who are not yet sick, but that's where as a healthcare or community worker going in to check in, you take your precautions, but try and cohort the groups that are already sick with the same symptoms, especially as you consider it's already cholera. And it's interesting, we talked about John Snow, right? But the point is, again, how do you try and prevent now the transmission to those who potentially may have not yet got infected? So something to consider.
Thank you, Dr. Trini. Now we'll move on to the final question. What are some other infectious diseases that may trouble them, this family? Yes.
Tuberculosis, because they're living in a small house, and obviously it will be overcrowded because there are a lot of family members living in only 2 rooms. So tuberculosis is also a possible disease that they may be facing. Thank you.
Okay, thank you, Farah.
right, Muhammad, we have some answers in the chat. Some said cholera, it's what they're having. Corona,
Type,
COVID.
Coronavirus, cholera, tuberculosis, COVID. Okay, so the question is directed to you, Dr. Trini.
Well, I think they are really all important in our differential diagnosis. I like the fact that you thought about how many people are living together. I'm assuming that they would have young children, so don't forget about measles, mumps, rubella, the MMR vaccination. I think that was brought up on what interventions may be done. And also, as you brought up typhoid, again, depending on the water source, the food source, we think about what we call as the enteric pathogens, right? Tuberculosis, because of them living together, less likely with the manifestation right now with these symptoms. And what you brought up, the seasonality. of these infections, and you brought up that that is the trend potentially in autumn of cholera outbreaks happening. So that would be also part of the differential. Now, I don't know how much of antimicrobial resistance the trends are for Sudan. I'm sorry, I didn't look that up. Many of you may be knowing it, but remember, whatever we give out into the environment through the gut microbes also can potentially contaminate and can lead to later on infections. So people could have a lot of different bacteria that is coming out. And when our gut is having problem, bacteria can also go into the blood of Candida. So those are some of the things. If people take a lot of antibiotics, they may get colonized with Candida because the antibiotics are killing the good gut microbiome, and then you get predisposed to other pathogenic microbiome, or microbes. So some things to consider what is happening as they are recovering from this bout of acute onset of diarrhea and vomiting. So just broadening your differential and anticipating the future, potentially, how do you help them to prevent other future infections?
Great, thank you. Thank you so much, Dr. Mathew, for that. And I hope you guys all, took something or two, a thing or two back home, because the students will be going to families and they will be facing this problem specifically when they visit the rural areas. So please always keep this in mind. And if there's anything you took away from today's session, I hope it would be like washing hands. That's the most important thing, especially as medical students. We go to the hospital and we work at clinics. Please just be sure to always wash your hands the correct way. The presentation is recorded and we do have the slides shared in the iEcho platform. So you can always go back to it. And I think Dr. Trini also had a link put in one of her slides, so you can go to the CDC website and just get to know the correct way and the flyers. All right.
And I'm kind of quickly interested to hear how many times have people observed them bringing their own hands to their face while they talked. Anyone kept track of that? Because that is the only way to protect the also from coming down from it with an infection. Anyone kept track where your hands are going? Too many to count. I was looking, yes. So that's one thing I leave you with. Remember the surgeon's hands, or what we call, once you've cleaned your hands, if your hands are together before you touch your face, you'll remember, oh, I need to wash my hands again. I've touched my face before I touch my patient. So keeping your hands together as you're listening, or if you answer your phone, washing your hands, you're bringing the phone close to you. Keep in mind, your hands are really crucial to protect you and to protect your patients. So that's something that I work on and encourage you to also keep thinking where your hands are and how can you keep them safe for you and your patients. Thank you.
All right, thank you. Thank you so much, Dr. Mathew. And again, thank you so much for that engaging presentation. And we've learned a lot. A quick reminder for everyone at the hall and on Zoom, these sessions are recorded and we do put the session presentation on the iEcho platform. This is the link on the screen. You'll be able to find this presentation. You'll also be able to find the past sessions. And we also do need you to be registered on the platform so that we can send you the certificates and everything. After every session, there is an email like this one where we give you the recap, the link to the recording, and information about the next session and etc. So please make sure that you are registered. You can just get the QR code that's on the past slide, or you will also find it via slide, so don't worry about that. Please go to the next one. Yeah, and about feedback, we do require a lot of feedback for our monitoring and evaluation team. So we would be very grateful if you could fill the feedback form on our website. It only takes about 2 minutes. It's about 13 or 14 questions. All you have to do is go to the website, click the session. For example, here it's applying quality improvement to vaccine hesitancy, and then you'll find the submit feedback button. So just click that and quickly go through the feedback form. We would be very grateful for that. We appreciate it very much. Next one, please. When you do go to the form, just please make sure that these logos do tend to show up there, because sometimes there might be a slight issue with a connection and it sends you to a different form. I believe it's happened a few times with people. So just make sure these logos are at the top there. Okay, next please. And yeah, I believe we're going to the end of the presentation. Yes.
Yes, I believe that's it. Thank you so much for joining in today. Happy New Year's and happy holidays. We would love to see you next time. It's going to be in January. So please just follow the student representatives and join our Telegram group. We will be sharing it to the groups. So the next today was the last session of our first phase, which was basically primary healthcare knowledge. In our next phase, we will be moving into a more advanced and medical knowledge sessions, where we will be handling endemic diseases in the Jazeera state, tuberculosis, schistosoma, and other diseases. So please just follow us in the Telegram group. And if we have any comments from our faculty, any last remarks, please feel free to open your mics and say anything. We have about 2 minutes.
Yes. Before we do end, I also wanted to thank Muhammad for the amazing presentation on the case, and thank you all who attended here with us for participating and engaging with us. It was a really engaging session, as I said earlier. I'd also like to thank Aditi from the ECHO India team for always being with us throughout all of our sessions from the beginning all the way to the end now. So thank you again, Aditi, for being here. And a final thank you, I'd also like to thank Dr. Tariq Al-Haj from the OBGYN department at the University of Jazeera. Thank you so much for joining us today, and we would be honored to have you with us in the next sessions too.
All right, I do not see, Dr. Amal, do you have any last words?
I would like to thank my colleagues, coordinator, Fatima Muttaba, and the student representative. Thank you so much. We will see you in the next phase.
All right. And the family medicine department, thank you so much for joining us today. And Dr. Mathew, happy holidays. We would love to have you in our next phase. We need to have you.
All right.
Thank you all. Please be safe. And we will be able to look after each other, but don't forget to look after yourself as we celebrate holidays and as we look after your patient. Don't forget to look after yourself and your families too. Thank you.
Thank you, everyone. Bye.
Tima, before you end the session, thank you everyone again for meeting, and you can feel free to leave now. Muhammad, I believe, or Mohab, you asked me to stay on for a few minutes. Do you have any issues at the hall or something you need?
No, just a second there. مش بقعد اسجل في الناس. Just give
Okay.
me a second.
All right, no problem.
رقية. رقية طيب. مسجلة في الويب سايت. قلت شنو؟ ما سمعك والله يا عيال. قلت شنو؟ فرح ما فهمتك. لا ما مشكلة في الأونلاين. طيب اسمه منو؟ لا دخلت لك اتصال مهند مش؟ قلت شنو؟ ما مشكلة ما أنا بسجل في 2 سنة من عندي.